Hi, welcome to the webinar. My name is Aisha McClellan, Share's Cervical
Hola,
Cancer Coordinator.
bienvenidos al...
And I'm Leticia Mercado, the Associate Director of the Office of Health Equity at Memorial Sloan Kettering.
Thank you for joining us today. This program is being put on in partnership between Memorial Sloan Kettering Cancer Center and SHARE. Before the program begins, I'd like to tell you a little bit about MSK's Office of Health Equity and SHARE.
Memorial Sloan Kettering Office of Health Equity was established to address disparities in cancer outcomes based on race, ethnicity, cultural differences, and socioeconomic status. The Office of Health Equity has three core focus areas, and that is patient access, research, training, and training. To learn more, you can visit mskcc.org.
SHARE is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with breast and gynecologic cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information, please visit our website at sharecancersupport.org.
A special thank you to everyone who's joining us today. We appreciate you taking time to learn more about financial burdens of cancer treatments. Now we have a few housekeeping reminders for you. This webinar is available in Spanish and English. If you would like to listen to the webinar in Spanish, please click the globe button marked Interpretation on the bottom of your screen and select Spanish. You will be able to see the presenters, but listen to the webinar in Spanish. All participants will be muted during the presentation. Once the speaker finishes presenting, we will begin the Q&A session. Please submit any questions through the Q&A selection at the bottom of your screen. Remember that the speaker is unable to give personal financial advice, so please keep your questions general in nature.
This webinar is being recorded and will be available on the MSK and SHARE website soon. Before we get started, we would like to learn more about you, our audience. Please take a moment to answer the three poll questions. 1, please tell us about yourself. I'm a patient, I'm a caregiver. I'm a family member, I'm a friend, I'm a healthcare professional. 2, have you been impacted by the cost of cancer or treatment care? And 3, do you worry about the cost of cancer treatment or care and how it will impact you and your family?
Thank you for participating. It looks like we have a fair number of healthcare professionals on with us today, along with family members and friends. And more than 50% have been impacted by the cost of cancer care. And majority, 90% of us on this webinar have worried of how cost of cancer treatment will impact you and your family. Thank you so much for participating in our polls. You are in the right place to learn more.
Now I'd like to introduce our speaker. Unfortunately, our original speaker, Dr. Thom, is not able to be here tonight, but we are very thankful to Dr. Tina, who has graciously stepped in last minute to present.
Thank you so much. I am going to share my screen, so hopefully you can see my slides soon. So I'm going to share that. And while that's loading, I'm just going to introduce myself. My name is Fumiko Chino. I am a treating radiation oncologist at Memorial Sloan Kettering. I actually treat in New Jersey as part of our efforts to improve access to care within the area of New York City, not just to Manhattan. And I specialize in the treatment of breast and gynecological cancers. And I'm excited to be back with SHARE, as I think I did a webinar maybe last year about cervical cancer and radiation. My main focus in research is actually in financial toxicity, or the burdens that patients have related to the cost of their care. So I'm happy to talk to you today about that issue. I am a poor replacement for Dr. Thom, though, who's my long collaborator on these issues. She is a PhD social worker who recently transitioned from MSK in New York to UNC in North Carolina. And we're going to be very sad to have her shift over down south. But I'm happy to talk to you about the cost of care and the financial burdens of treatment. What I'm hoping to give you is just a little bit of a background about the concept of financial toxicity, so defining it and contextualizing it in terms of the lived experience of cancer care, and then talk about some potential solutions kind of across the healthcare system, so both in terms of, for example, medical debt, also managing medical bills, and, for example, empowering patients with a little bit of knowledge, in terms of health literacy and health insurance literacy, and then specifically talk about some potential resources in order of improving affordability. My main focus is financial toxicity, which is the problems that a patient has related to the costs of their medical care. What I try to emphasize to both patients, but also people within my healthcare system, within my hospital, and then other researchers and other cancer doctors across the United States, is that financial toxicity is a toxicity just like any other. And a lot of people, when they start their cancer treatment, are warned that they may lose their hair, if they're going to do chemotherapy, or maybe if you're going to do radiation, that you might have skin effects, you might have a radiation skin burn. But very few people are warned about the toxicity that comes from these high costs. And like any other toxicity, it really can affect people differently. So some people never have painful peripheral neuropathy from their chemotherapy, and other people are crippled by it. And so similarly, these costs can really have, differential effects for people with cancer, causing great hardship to some people. But then other people don't even really notice that there's a problem. And I think, this kind of variability of how effects are found on people really highlights the financial toxicity as an equity issue, meaning that not everyone can afford to get the best care. We know that financial toxicity specifically has measurable effects on patients. We know that it's associated with decreased quality of life for both people on cancer treatment, but also cancer survivors, meaning even after a cancer diagnosis and treatment is complete. We know that high costs can actually be associated with decreased satisfaction with care. It can even erode the trust that patients have with their doctors, their health insurances, or their healthcare systems. And we know that high costs actually can decrease adherence to treatment, meaning that patients have to sometimes cut corners because they can't afford their cancer treatment. They have to skip scans or visits, or they may not take all of their medications because, quite simply, they can't afford them. We also know that certain things are increased when we're talking about high financial burdens. We know that personal and family burdens are increased related to a cancer treatment. So I always say that it's not just the patient that's affected by financial toxicity, it's also the entire family unit. And we know that some patients, that financial burden that they face from a cancer diagnosis is going to affect their spouse or their kids, or their capacity for continuing to work, and their lifetime capacity for even getting the job that they want or the education that they meant to pursue. We know that there's an increased risk of bankruptcy related to high costs, meaning that patients have to declare bankruptcy at much higher rates. And we know that there's a lot of additional distress that patients and families feel related to the costs of their care. this is all part of a background that is related to structural racism and inequities within the healthcare system in general. So it's not just your capacity for receiving care, but how far away that care is from you. Whether or not you have good access to good nutrition, whether or not there's a lot of pollution in your neighborhood, and whether or not it's safe. Even some things like your savings walking in the door from a cancer diagnosis, where some people are, able to rely on that savings as a cushion, as a buffer, but other people don't have savings at all. Other patients may have varying capacity for even understanding their diagnosis or kind of their treatment plan. The health literacy can be quite variable. And people are just trying to, get through their cancer treatment, much less understand their bills or their health insurance. And my standard joke is that I am an MD, a medical doctor. I do research in health access and affordability and insurance types. And it still took me 2 weeks to decide which plan in my employer-sponsored healthcare to enroll in, because I had to look at all the plans and even decide what was right for me. And I don't have cancer. And I don't have a lot of chronic medical concerns. So this is really complex. When I try to level set, meaning, to give everyone a baseline of what we're even talking about for financial burdens, I usually point to this opinion survey, which was put on by the largest group of oncologists or cancer doctors in the United States. And it shows that there's actually slightly more people who were worried about the financial burdens of a cancer diagnosis than from dying of cancer. And I think that kind of puts it in a grim reality of, for some people, when they hear the diagnosis of cancer, their first question is not whether or not they're going to survive, but whether or not they're going to be able to afford the treatment. The work in financial toxicity was really built on 2 different research studies that put it into a context of bankruptcy and death. And these were published not even 10 years ago, showing that patients with cancer were much more likely to have to declare bankruptcy. And then for those people who had cancer who declared bankruptcy, they were just much more likely to die. And it puts it in really grim terms, which is that if you have this ultimate negative financial outcome, bankruptcy, you can also have the ultimate negative physical outcome, which is death. We know that the fact that cancer care is becoming more and more unaffordable is really driven by many different people across the healthcare system, from the people who make the drugs, the pharmaceutical industry, to biotech, or the people who are, for example, developing the next greatest test, to providers and healthcare systems, so doctors and hospitals, and insurers, the people you get your health insurance from, and people who are paying the larger portion of medical bills. And so we kind of all carry this burden of both being trapped in, but also sometimes perpetuating these high costs for patients. And it really does require kind of all of us to think about, how do we, at a system-wide, improve the ultimate care that we provide, not just in terms of the best, latest, greatest cancer treatment, but also making sure that people can, just afford even last year's cure, right? The context for understanding how we address affordability and financial burdens or toxicity is, within the larger healthcare system and policy environment, all the way to kind of the state level, to your institution or where you receive healthcare, your hospital, to your provider, which is, your doctor, your nurse, all the way to the patient and family, with the understanding that a lot of people actually get their health insurance through their employer. And so part of that aspect of care is really important as well, because employer-sponsored health insurance can go away if you stop being able to work. I want to point out some of the work that's been done already to improve affordability, which is that, when we think about the care that is available within your hospital system, there is a real disconnect. I always call it's a misconnection between the people who have need for example, financial assistance programs, and the actual people who are facilitating the access to those programs. So essentially, a lot of hospital assistance programs are underutilized, meaning that they're just not accessed by the people who really need them. And so the people who need them don't know that they exist. And the people who have kind of control of those systems don't know which patients are going to benefit the most from those services. And so this lack of communication is really frustrating on both sides, because it means that there could be essentially, money on the table to help people, and it's just not being used. When we think about how to improve this, we can think about different ways along, again, the kind of care cascade. We can improve things like education or navigation or actual monetary assistance for patients and caregivers. So for example, within patients and caregivers, we can potentially improve things like financial literacy. So a lot of people don't get anything in their school about bank accounts, or what the difference is between a savings and a checking account. Or most recently, I'm a doctor, keep in mind this is embarrassing, I didn't know what a money market account was. At one point, I just had some money in my checking account. It was just sitting there, and I had a friend who said, "You should move that over to a money market account so it will actually make money for you." And I said, "Oh, okay." I didn't get any education on that, and I went to many years of advanced schooling. So just basic financial literacy is really important. Health insurance literacy is really important. Again, the types of plans and the benefits that you get from those plans. And then health cost literacy. So my background before medicine was as a cancer caregiver. I took care of my husband when he was diagnosed with cancer, and we would get these EOBs, explanation of benefits, in the mail, and they would have these astronomically high prices on them, which were terrifying. And it was very hard for me to understand, what is this? Because we would also get bills. We would get bills from many different people, so from the lab or the hospital or from the doctor or from the anesthesia team differently. And it was very challenging to figure out what needed to be paid and who needed to pay it, from my health insurance company to myself, to what we could potentially safely put off or put on a payment plan. We can also think about education for the patient in terms of financial counseling. So not just abstract concepts, but like for you specifically, what can you expect for your cancer treatment? Because you're going to need surgery and radiation and chemotherapy. What are the components of that care, and what maybe could you expect in terms of your out-of-pocket maximum for the year? Meaning, what can you think mentally prepare for to budget for your cancer treatment? That's financial counseling. And then making sure that we are, leveraging those existing resources. So, what is available at your cancer center, or within the larger kind of charity nonprofit world that could help you afford your care better. So some examples of this in terms of education. So there's some studies specifically looking at whether or not we can improve health insurance education, or if we can improve cost conversations, meaning making people feel more comfortable raising up their costs with their physician, with their doctor, so that it can be addressed properly. Because again, as a cancer caregiver myself, I never brought up the costs that we were experiencing that were really actually terrifying to me and to my husband with my physician, because I didn't realize that it was appropriate, or that honestly that he could do anything about our costs. I know now as a physician that he could have, and that we could have gotten some extra help, which is, disappointing to me. But it does mean that, empowering some of those cost conversations can potentially make a difference for other patients. When we think about navigation, so we want to consider, well, is there general financial navigation, meaning that, this is, the potential, co-pays that you have related to your scans or your radiation. And then specifically within your own health insurance, this is what you can expect to max out at, meaning that every health insurance, at least in the United States, has something called an out-of-pocket max, after which your health insurance fully covers your treatment. So if you know what your max is, you know that, well, I know that I'm going to pay $8,000, but I won't have to pay more than that for anything under this part of my insurance. I might have to pay separate costs for example, medicines, which might be under a different part of the policy. But knowing that can be very helpful. And most people don't. When they get diagnosed with a cancer treatment, they never pick their health insurance plan based on their out-of-pocket max, because why would they? They were healthy. There's different ways that we can think about how to best give this to people. So for example, via a mobile app, on a website, either like a text-based phone message, or even in person, in terms of thinking about the optimal way of navigating for patients. There's a couple of different studies that show that actually these things can actually help people improve their care. So navigate them, for example, to a better health insurance plan for them when they have the possibility of changing their health insurance to just get a better plan. Sometimes it means paying more upfront, but it covers more. Sometimes it's a matter of making sure that you know about the pharmacy assistance programs that are available to you and can apply for them in a timely fashion. All of these kind of fit under this concept of navigation to improve how people are able to access and afford their care. In terms of actual assistance, there's different ways that you can get help affording your care. Copay assistance is, when you have, for example, an expensive medication, that there are different programs that could potentially help you afford that better. There are things, for example, like direct cash transfers. So, if you have a non-medical need, maybe you, have your utility bill and your lights are about to be turned off. A lot of cancer centers are actually be able to help with a one-time kind of need like that. There are grant mechanisms that are available that if you have a potential, big expense in the future, the most common that I can think of is for fertility preservation, that can help with that. The support for essential needs, like again, food, housing, transportation, that kind of goes in with that concept of non-medical needs. And then of course, for mental health support, utilizing all of the available resources like free group chats, online support groups, etc., that can help support your mental health, in addition to physicians or therapists that have either charity or sliding scale assistance for people who have mental health concerns. So just to kind of go through some examples about potential assistance that is available. this we have the concept that maybe for people with cancer, they should have something like a guaranteed income. So this is currently being studied. Sadly, I can't tell you that you can enroll in it right now. But for people with cancer, maybe it would just be helpful to have an extra $500 a month, right? For the time that you have cancer, like if you were able to rely on that income, it could make a big difference in terms of affording care. The one-time financial grants for young adult cancer survivors was just recently published to look at, well, if you do get a $2,000 grant specifically to help pay for the cost of fertility preservation, or if you have your lights are about to be turned off, how does that help you now, but also potentially in the future? There are studies that are specifically looking at food banks. So can we put a food bank in a clinic where you receive your cancer treatment so that you can meet your essential needs, meaning lack of food, and also still get your care? The food program at MSK also developed a system where there could be food vouchers or food delivery for people who were receiving cancer treatment. And then my own study specifically looks at even just stupid things like the cost of parking, how if we can potentially offset those costs for patients, that it could make a difference in order, for people affording their care. For providers, so for physicians and for nurses, we can really think about how do I, as as someone who does this research, how do I make this important to your doctor? How do I convince them that this is an important conversation to have? How they need to be advocating for you within their institution, within advocacy issues like in Washington, D.C., to move forward key issues that are really impacting our patients. How do I feel more comfortable as a physician having a conversation with my patient about whether or not they're able to afford their care, so I can normalize that conversation? How do I make sure that when I document in my note, that this person has to work, right? And these are their hours, and they work these days of the week. And then that means it's a priority that if there's a Wednesday appointment and that's their only day they don't work, that's a priority than over someone where it's just more convenient for them. It makes a difference, right? As a radiation doctor, when I'm trying to get that very first appointment in the morning, I put in bold capital letters, this person works full time. They need that 7:30 in the morning appointment so that they can continue working. That's important for me as a provider to document. And how do I make it sure that other people are, relaying that information? And then again, for physicians, how do we prepare people better to know kind of what the future holds? So for me, as a radiation doctor, if I know that there may be an insurance battle to get their radiation approved, I always warn people in advance. I say, you may get a scary letter in the mail that says that your treatment is not approved. I want you to know now that I am going to fight that on the back end, and that you don't need to waste your time or get involved in it, because I will get the things approved that I know are going to work for you. And that provides a lot of upfront reassurance to people. And then sometimes I see them like on their first treatment visit, and they show me I got the letter. And I was like, I know, it's okay, it already got approved. But it helps decrease anxiety relating to that. And that, again, that's part of that idea of like, how do we better educate providers to deal with these issues better? Thinking about some of the benefits of education for both patients and providers about, for example, cost conversations. We know that cost conversations, having a discussion about care being unaffordable, can help patients afford their care better. For the most part, it's that misconnection thing. It's making sure that people actually get the financial assistance that's actually available and that they qualify for. Sometimes it's me as a physician, talking directly to your insurance and, making that argument for them, taking more of my day, obviously, but, it's worth it because the patient actually gets the care that they deserve to get. Sometimes it is switching to less expensive medications. I've done that before when some random medication was just crazy expensive. But we only know that there's a problem if we ask or if you tell us, right? And if there's silence on both sides, like it's just a missed opportunity to help people afford their care. We know that there is better roles for things like navigators in terms of doing good needs assessments, meaning that some people walking in the door were already at risk of having their lights turned off, meaning before a cancer diagnosis. So cancer is the thing that can push you over to that financial instability, and just missing, even if you're able to continue working, just missing 1 or 2 days of work is the thing that then makes you late on your car payment, and then that makes it so you lose your car, and it's like a cascade of negative repercussions from one health or wealth shock. We know that there are better ways that we can be more proactive about helping people, even from information that we already know, to get them connected to community resources or support groups, or things like financial planning tools, or copay assistance. Again, this concept that maybe we shouldn't wait until you get the $7,000 bill before trying to help you. Maybe we should try to work in advance to try to provide that help upfront. Again, navigators can play a big role in terms of patient education as well. On the hospitals, when I make, the big argument within our healthcare system about what we need to do, how to improve care for every single person, not just the person in front of me, because I know I'm going to try to work doggedly to improve the care for the person I see in clinic tomorrow. We can think about how do we screen better. So everyone, when they come in for their cancer treatment at my institution, gets a falls assessment. Have you fallen recently? They also get a depression screen. Are you feeling blue? Are you at risk of harming yourself or others? And why aren't we doing just routine screening for financial concerns, right? So could we just be using some of the time that we have with people better, so that we can make better pathways to help people more efficiently? I think one of the things I always try to highlight is that telehealth did a lot to improve access to care, but then it kind of went away. And whenever I always offer telehealth to people, not everyone does, but whenever I have a telehealth visit and I see someone is actually at work, or sometimes they're talking to me in their car because they went out to the parking lot because they don't have an office, I'm actually kind of happy, because that means that they didn't need to take the day off of work to talk to me. And that's nice. I mean, it sucks. I wish that people could take the whole time off and just, focus on me. But I also know for some people, they need that income from that day of work. And so offering them telehealth means that they didn't need to take the time. They didn't need to lose that income for that day, which makes a huge difference. For me, arguing with my institution about, for example, streamlining how we bill patients, making sure that we're able to give people options for payment plans, for example, that people are going to have an idea of how much their bills may be, which is called price transparency. Making sure that we are again making that connection between the financial assistance that's available and then what's delivered. It's really important. And then making sure that we are checking for everyone when they walk in the door. If you're having food insecurity, you can't afford to feed yourself or your family, and you had that before a cancer diagnosis, we want to make sure we're plugging you into the resources that you already qualify for. And we're doing that seamlessly, because a lot of people don't want to ask for that. It's too much on top of a cancer diagnosis, and so it doesn't get addressed. And then if it doesn't, if no one asks the question, then we'll never be able to, answer it. Within the community, always try to say that there are, personal networks of support. So when my husband was diagnosed with cancer and we were facing enormous financial hardship, we actually got personal loans from my family, which again, we have the privilege of having family that were able to give us, money to help out. And so a lot of patients actually rely on their personal networks. There's advocacy organizations that can help offset costs. And there's actually a growing world of crowdfunding out there for people who are actually fundraising for their cancer treatment, or sometimes for their fertility treatments, or for specific needs to, for example, travel to go to a clinical trial. And I wish it wasn't, but it's actually a very valid way of raising money to help afford cancer treatment. I do some work on the policy issue, meaning that we all know that the healthcare system is broken. No surprise, hopefully, to anyone on this webinar. And it does need to be fixed from the top down. It can't just be me pushing forward and patients pushing up. It needs to also come from the top down. And so there's a number of different things that we can think of to improve both how insurance is designed and paid for, how cancer treatment is paid for at the insurance level, how Medicaid has been able to be accessed, and then things like, prescription drug prices. In terms of medical debt, I always try to stress that it can affect anyone. There's certain populations that are at higher risk, but when my husband was diagnosed with cancer, and unfortunately when he died from cancer, we were left with over $300,000 in medical debts. And those debt collectors called me as a widow for many, many years, trying to get that money from me, like blood from a stone. And so medical debt can be really insidious, and it can carry on even after the person with cancer has died. We know that there are specific consequences that are kind of downstream. So, obviously credit score being damaged, your general economic stability, obviously, but bankruptcy, losing your house, for example, obviously what we talked about in terms of people having to skip or delay care. Even just accessing things like, for example, we have some good evidence that acupuncture can help for peripheral neuropathy when you have painful numbness and tingling, or it can help with hot flashes. A lot of people can't afford to pay for acupuncture because it'll just put them in much more debt. And so it's a real barrier to access for them. And then again, those debt collector calls are very emotionally distressing. I can tell you that personally. When I think about hospital systems, again, thinking about how to improve care, what we're trying to do is optimize communication, billing, prices, and again, that missed connection, or making sure that financial assistance is getting to the people that can really benefit it. Again, kind of circling back around to navigators, we're trying to make sure that patients actually have better ideas of what their rights are. So for me as a cancer caregiver with debt collector calls, I had to start doing this research before I realized that I wasn't responsible for my husband's medical debt. And your own rights as a patient, or what your caregiver rights, those are really important things to know, but nobody's taught this in school. Again, that concept of financial literacy and health insurance cost for literacy, and then what your actual hospital policies are. So for hospitals that are that have a mandate to provide care to the community, they often have they are also required sometimes to offer a payment plan, or to offer discounted services for patients who can't afford their care. And it's really important to know that if you qualify for that, because they may not offer the information to you up front. Facilitating communication, and again, selecting the right health insurance, or right sizing the health insurance. It's all part of that kind of next step of improving care. And again, just connecting patients to resources. From providers, again, we talked about this already, but this idea of communication, making sure that patients are made aware by their providers about referrals. So if I send someone to physical therapy or acupuncture. We always talk about things like copays and sometimes how health insurance doesn't cover X, Y, or Z. But I also, if I know I'm out of network for someone, meaning that they're going to pay a much higher price for my treatment than someone who's closer to them or in network, I will be honest to say the differences in what they may receive and whether or not I feel like it's worth it. And for a lot of people, it is not worth it. If I'm just going to treat them the same way that the person, even if we're both the same copay, but that, they're 5 minutes closer, maybe it's just worth it to go to the closer facility, because if I'm not going to do anything different, if there's not going to be a lower quality of care, you should go to what's more convenient. For providers, for us, again, just thinking about how we are making sure that we're asking those important questions. So what is the psychosocial impact of your cancer diagnosis and treatment? Because ignoring those issues is the best way of not treating them. So we need to make sure we're providing the best facilitated care and, of course, advocating for them. Again, circling back around to this concept of, for prevention, knowing all of these aspects of hospital billing and your insurance. And then for management, making sure that even though opening that bill every month, every week, every day, I know I got medical bills every single day. It was important for me to at least know what I was supposed to be paying, even if I then chose to ignore it. But to not just leave those unopened stacks of bills, because you may not realize that, that one of them is the key one that actually does need to be paid. And realizing that, again, cancer can affect your credit score. So thinking about how to be more savvy about making those decisions for example, your future financial health. Focusing at the end on just some resources. So of course, there's resources within the professional associations, meaning things like ASCO or cancer.net. There's actually, again, I'm a researcher, so peer-reviewed publications. So what's available from the published literature, meaning like what researchers are putting out there, and then what's available online that are more patient-facing resources through, again, the American Cancer Society, Triage Cancer, Family Reach, or the Association for Community Cancer Centers. These are all places that actually have really good resources that I would encourage you to look at. The last thing is just to highlight some specific nonprofits. So for example, Cancer Care can provide a social work consult, can provide some limited financial assistance. Expect Miracles can provide one-time cash payments. Triage Cancer can help you negotiate, for example, with your work or let you know what your rights are. The ACC actually has a financial advocacy network that can help you if you're receiving your care within a community cancer center. Family Reach can provide one-time payment support for things. And then the Cancer Financial Assistance Coalition is a similar nonprofit. All right, so I've finished it up. I'm so sorry. It was an exhaustive step. I was just trying to say we need to help on a systems level, right? But it doesn't mean that you shouldn't get help right now at an individual level. I will not acknowledge this is key. Just, listen to me blather on for 35 minutes, I think is important in terms of making sure that you feel empowered to bring up these issues with your health provider team, and make sure that you get all of the help that you qualify for and that will benefit you. So I am going to stop sharing and hopefully answer some questions.
Thank you so much, Dr. Chino, for that presentation. We're going to start the question and answer now. For everyone on the call, you could submit questions in the QA section at the bottom of your screen. We will try to get through all of the submitted questions, but we may not be able to due to time constraints. Remember that the speaker is unable to give personal financial advice, so please keep your questions in general in nature.
Thank you. All right. So the first question we have is, does the money I pay for cancer treatment impact my taxes? Can anything be written off?
That's a really good question. So there is something called a health savings account, which is it's called a tax advantaged account. And if you have a health savings account, it can everything that you use from that is tax advantage, meaning that you don't pay taxes on, is taken out pre-tax. If you do not have a healthcare savings account, I do not know. There may be more specifics on the state level for that. The easiest thing to point to is that HSA. Those are variable based on your employee on whether or not they're offered, and it is maybe one of the ways where health equity differences can really be noticed for patients. So not just that the quality of health insurance that you're offered, but also some of the added benefits like the HSAs can be quite different based on the population. And for wage workers, you're less likely to have good health insurance options, and less likely to have things like HSAs available to you. Having said that, if you do have the option, I would 100%, and you have cancer, I would sign up for a health savings account, and I would max it out every year. Typically, they're able to roll over for at least 1 year. So even if you don't use it this year, you can use it next year. And things like dental, eye vision, it can all be used for that. You can even do, some vitamins and supplements, depending on what they are. They can be used. You can use your HSA for.
Thank you. Next question is there financial aid available for people who are retired?
Good question. So typically financial aid is available based on an income level. So what they'll do is ask for things like pay stubs, or for people who are retired, it depends on what your passive income is. So if you have Social Security, or if you have Social Security disability, those things are all part of your income, and then you would qualify based on that. So I would say most people who are retired, they are not going to have much active income, unless you have like a lot of stocks, in which case good on you. So you would still, in theory, be able to qualify for financial assistance depending on your need. There are some programs that are limited to younger patients, and so there are some specific charities that are really just for younger patients. So, for example, Family Reach prioritizes financial assistance to people who have young kids in the home, and the Expect Miracles Foundation similarly is focused on that, but that doesn't mean that all cancer charities are focused on that.
Is long-term or hospice care more affordable at home or at a facility?
So in general, when you think about facility care, it's more expensive. There's a limit in the number of days that you qualify for. So hospice services can be provided at either, but the long-term care component is what tends to be the most costly, because as you may know, family caregivers are the unpaid glue that keeps the US healthcare system working. And when you don't have, for example, a family member to help take care of you, then facilities are sometimes the only option, and they can be very expensive, and there can be limits on how many days. So in general, it's more affordable in terms of a facilities cost for you to get hospice at home. But it requires more assistance from your family members to help provide caregiving. It's one of the things that I've actually really loved about being in New York, is that there is actually designated family caregiver benefits, meaning that, like, if your family member is out of work because they're caring for you, they could potentially get paid as part of a reimbursement program through your health insurance. That is something that I think is only available in New York State, which is stinks. But I think it shows that there's a lot of benefit that can be done at the state level to advocate for those things, because New York did it. So why shouldn't Texas do it, or California?
Good point. Are there financing options available for medical care other than what's offered by a provider?
So I would say that most providers don't know at all what it's going to your medical bill is going to be at all, and if you ask them, they're going to have no clue. Within your hospital system, though, within your cancer center, typically they are going to be able to offer you certain payment plans. That's actually required under the basically federal legislation is that hospital systems are obligated to offer payment plans to patients that can't afford their care. Outside of those, though, you'd be in the kind of the private debt world, so that'd be credit cards or private loans, which would be a way of financing medical care, and that gets into quite variability in terms of the quality of rates that you would get. So I think there are options. I don't know if they're great options, unfortunately.
Can you only find financial resources or aid before you begin treatment?
No, that's a good question. So you can, all along the care cascade, there are potential resources available to you. And so, for example, a lot of patients with, for example, metastatic or stage 4 cancer might be on treatment for many years. And so when they were still working and, you know, you had an income coming in, their care was more affordable. But then if they had to stop working, or if their situation changed in some ways, they may have new barriers to care, new affordability barriers later on. And so they can certainly apply for it at that time. And it's one of the reasons why I advocate for things like routine screening. So again, that falls risk assessment, that can be the financial risk assessment. Every time you see someone, if we could be asking you if you're having any problems affording your care, then we can catch those people that were doing fine, and then they fall off a cliff. And that's certainly what happened to me, you know, with my husband's care. We were doing fine, and then we got a $200,000 bill.
Actually, that falls right into our next question. Is there an agency or reference that could help manage debt?
So typically it depends on where your debt lives. So if it's with the hospital, then typically the hospital is the best person to talk about managing that debt with the patient financial services group or whatever it's called at your hospital. Sometimes they're called different names. Generally, if you have, for example, a social worker that you're working with, they can also kind of tap you into certain facilities or certain resources in terms of education. If your medical debt has already been kind of sold from the hospital system, which again, for me, having medical debt that's been was sold and then sold and then sold, the person who's still, it's been over a decade since my husband died, and I'm still getting occasional debt collector calls. That person who's calling me now is like so far removed from the original hospital that carried the debt that they have no, I'm not planning on negotiating with them. So I will be honest, because it's not anyone who was ever involved in actually providing care for my husband over a decade ago. So it can be confusing. I think that the primary focus that I would emphasize is just find out who owns your debt. And if it's still within the hospital system, it's much easier to negotiate with than if it's with a debt collector. And sometimes actually debt collectors will kind of portion out your debt, like this company owns this part of your debt and this company owns this part of your debt. And it can be very, very confusing. I will also say that debt collectors is like the wild, wild west. And a lot of them do not adhere to the law in terms of saying what you are not responsible for, what they can do, you know, in terms of making threats. It can be quite scary. So I would always make sure you know your rights in terms of what they can actually do for your financial future, and what measures that they can take in terms of collecting on that debt.
How can we find someone to help us navigate resources to deal with financial toxicity if our cancer center does not have a social worker or the social worker is overextended with too many patients to serve?
Yeah, so this is a common problem for people who, again, I'm speaking from a position of privilege, being at a world-leading cancer center who has phenomenal social workers and, like a lot of resources. A lot of people who are receiving care in the community. And so the example I'll give is that my mother is a radiation oncologist. She's the same type of doctor that I am. I learned from the best. But, at her facility, the patient financial services counselor is also the billing person, is also the person who does some social work, although they were never trained to be a social worker, and is also my aunt. It's there, people in smaller centers wear many hats and they're definitely overstretched. I would say in that situation, an outside resource, something like Cancer Care, that can provide social work assistance and helping you organize kind of the resources that may or may not be available for you, could be very helpful. So these national nonprofits like Cancer Care, or again, Family Reach, can be very helpful. Even just some of the information available on Triage Cancer can be really helpful, because they have very helpful like checklists that you can go down and say, okay, like this is the information I need to acquire. And this can help me at least understand, for example, my health insurance better, and what it is and it isn't going to pay for, and what can I expect in kind of the given year.
Thank you. Are there any resources for getting healthy food or supplements outside of drugs or treatment?
Yeah, this is such a good question, and actually, I just had published research on this specifically for patients with breast cancer, actually, about how supplements and vitamins and things like holistic treatments like tinctures can cause a significant financial burden on them, and that can actually have downstream effects that then also put downward pressure on their capacity for affording other medications. I also have some research supporting about the fact that people are paying a lot for things like CBD and cannabis. So, again, things that are not necessarily prescribed by your physicians, but that people are taking and are endorsing a lot of very positive benefits from. I would say in terms of foods, unfortunately, food banks, although they are available to most people under a certain income level, they're not necessarily the healthiest foods that are available, because it's usually shelf stable. And so that can be very challenging. I would say that there's quite regional differences in terms of what food's available and the quality of the food that is available. I do not know a specific assistance that can help with things like supplements or other like things like vitamins, which can be really a big financial hardship. We're just at the point where we're kind of realizing that these things are very expensive for patients. And so I think it's a kind of an evolving research focus for people like me, at least, to try to think about how do we treat the full person, not just their cancer, but again, thinking about how for a lot of people that get some benefits from these things, how are we helping people afford all of that care? I will also mention that that the supplement industry is virtually unregulated. Anything can be in anything, and some of the things are quite expensive, and it may not be worth it, depending on kind of what you're getting and what quality that it is, and how expensive it is for you.
Well, it looks like we're about to be out of time. So thank you, Dr. Tino, for such an informative program. And thanks to all of you for participating and submitting questions. And please note that the slides and a recording of this presentation will be available on our website at sharecancersupport.org in about 1 to 2 weeks.
Great. Thank you, everyone, for joining us. Please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be in a follow-up email. All surveys are anonymous. Thank you so much for joining us this evening, and thank you, Dr. Chino, for joining us as well.
Thank
Have
you.
a great night.